Hello, thank you for viewing this provider training for the Reverse the Cycle program that is being implemented in the emergency department at Summers ARH. Today, I will review with you the Reverse the Cycle model and how it is being implemented at Summers and help you understand the role of the provider in one of the components of the model, which is medication for opioid use disorders initiation in the emergency department. I will help you understand the role of the peer recovery coaches and how they will contribute to patient care. You'll be able to follow the clinical guidance and protocol to support the initiation of medication for opioid use disorder after viewing this training. To give you a little background about why we are here, the Reverse the Cycle model is a comprehensive substance use response model that's designed to work in emergency departments and has been implemented in over 50 hospitals across the nation, including Beckley ARH and several other ARHs in the state of Kentucky, such as Hazard, Whitesburg, Harlan, and Highlands ARH. As we look at substance use, we recognize that it is a national public health crisis. In 2020, drug overdose deaths soared to 45% since 2019. According to the CDC, there were over 100,000 overdose deaths reported in 2021. 2/3 of those deaths involved fentanyl or other synthetic opioids. Taking a look at West Virginia overdoses, you will notice as we began to see some decline from 2018 to 2019, we saw a huge spike in 2020, directly related to the COVID pandemic. Although the 2020 data is preliminary, we are fortunately at this time seeing significant decline in the number of overdoses. Taking a look at fatal overdoses by drug type, we see from 2015 to 2020, all opioid overdoses, which includes a combination of heroin and fentanyl, spiked by 38%. Fentanyl spiked by 14%, methamphetamine by 6%, and heroin actually declined by 1%. Now, what you might be wondering is, what can be done to confront this crisis? I'll now move on to providing an overview of how the Reverse the Cycle program addresses the national substance use epidemic we are facing. Mosaic Group and West Virginia's DHHR SOAR team recognized the need for a more powerful response to this public health crisis. There are 3 components to the Reverse the Cycle program I will now walk you through. It includes first beginning with universal screening completed by nursing, followed by peer intervention by a team of peer recovery coaches, and lastly, the opportunity for patients who are eligible to receive an initial dose of buprenorphine in the emergency department. Beginning on June 20th, you will notice 2 new employees in the emergency department at Summers. Their names are Christina and Glenna. They are peer recovery coaches. Peer recovery coaches are individuals in long-term recovery, and they will be providing peer support services to patients presenting to the emergency department who report alcohol or drug use. Christina and Glenna will use their lived experience to help patients that are in active addiction. They will have a conversation with patients about their substance use. They will assess patients' readiness to change and make referrals to treatment as appropriate. Their hours will be Monday through Friday from 7 a.m. to 11:30 p.m. with an on-call schedule on Saturday and Sunday to respond to any overdoses that present to the emergency department. The peer recovery coaches will also see patients in the local Summers community. The community-based work will include providing intensive outreach and follow-up with patients who have presented to the emergency department following an overdose. I will explain more about the community-based work later in the training. Next up, I have displayed for you here is a visual that shows an overview of the peer recovery coach's workflow. It begins with all emergency department patients 18 and older completing a universal substance use screening with the nurse during triage. If a patient screens positive for risky substance use, the peer recovery coach will receive an alert on their track board in Meditech that there is a patient with risky substance use who needs to be seen. The peer recovery coach will then review the patient's results on the screening, review their medical history, and understand the reason for the patient being in the emergency department. The peer recovery coach will then meet with the patient to have a conversation about their substance use. Based on the conversation the peer recovery coach has with the patient, in collaboration, they will make a plan to address the patient's substance use. This plan could be anything from a referral to treatment or a plan to reduce use. During triage, the nurse will ask all patients over the age of 18 a series of questions to better understand their alcohol and drug use. There will be occasions when a patient will deny use, and when you see them in their room, something comes up during the course of your visit with them that indicates they are using alcohol or drugs at a risky level that is concerning to you. These patients should be seen by a peer recovery coach. But if they did not report use during triage, the peer will not receive a notification to see them. Therefore, in order for the peer to provide an intervention, you as the provider must communicate to the nurse there is a provider request for the patient to be seen by the peer recovery coach. The nurse should then put in a consult in Meditech for the patient to be seen by the peer. Provider requests should be selected when patients will not answer the screening questions in triage, but you as the provider suspect they may use drugs or drink at a risky level. Or the patient has denied use, but you suspect they may use or drink at risky levels. The second component of the program is the Overdose Survivors Outreach Program. This component of the program will help address the overdoses in Summers County. The peer recovery coaches will provide community outreach to these survivors. The support that will be offered to patients is really focused on working with the patient to prevent a subsequent overdose. The peer recovery coach will have weekly and sometimes even daily contact with patients to support their recovery. The overdose survivor will be seen by a peer in the emergency department. The peer will provide the patient with education on how to prevent another overdose. They will then engage the patient in the OSOP program, which is an extension of the recovery support that begins in the emergency department. Both Christina and Glenna will carry a caseload of overdose survivors and work with them for a minimum of 90 days to ensure they are connected to recovery support services, such as substance use treatment. The last component of the program is initiation of buprenorphine in the emergency department, followed by fast-track referrals to treatment. There's a great deal of research and science that supports medication-assisted treatment for opioid use disorders does save lives. I want to share with you some of that research. It has been found that medication like buprenorphine is estimated to reduce mortality by up to 50%. It has been linked to reduce risk of overdose-related deaths, and the risk of opioid overdose death declines immediately when patients with opioid use disorders are initiated with buprenorphine treatment. Furthermore, buprenorphine is associated with improved social functioning, decreased IV drug use, reduced HIV transmission, and better quality of life. You may be familiar with the D'Onofrio study out of Yale, where they similarly, out of an emergency department, had 3 study groups. One was initiated with buprenorphine and a 3-day prescription, with a referral to a primary care provider with continued maintenance therapy. One group received a brief intervention and then got a referral to treatment with no medication. And the third group received a simple referral to treatment. And what you can see in terms of engagement and treatment at 30 days was their retention in any self-reported illicit opiate use, as well as their toxicology report for opiate use. The group who received buprenorphine in the emergency department with that coordinated link and bridge to care did better across all 3 components. They were retained in treatment at a 78% rate, much higher than the other 2 groups. Their self-reported illicit opiate use was fewer days, and their urine toxicology negative was at a higher rate than the other 2 groups as well. When we think about practitioners using narcotics to treat opiate addiction, there is a separate registration or waiver needed. The Drug Enforcement Administration has an exception to the registration requirement, which is known as the 3-day rule, which allows practitioners who are not a waivered provider to administer but not prescribe narcotic drugs to patients for the purpose of relieving their acute withdrawal symptoms while a patient's referral to treatment is being arranged. Under this exception, emergency department physicians are permitted to administer buprenorphine to patients for no more than 72 hours. The peer recovery coaches will refer patients to you so they may be considered to receive an initial dose of buprenorphine in the emergency department. The protocol for this component of the program outlines that any patient who is opiate using and reports motivation for treatment should be referred to the emergency department provider to be considered to receive an initial dose of buprenorphine. The peer recovery coach will not refer the patient to you if they have not made a commitment to go to treatment after leaving the emergency department. So when we think about initiating medication in the emergency department, we know that patients who begin or are already experiencing withdrawal when they are in the emergency department could receive a combination tablet of buprenorphine and naloxone to feel better, allowing them to participate more actively in their health care. When patients feel better, which happens almost immediately after receiving the dose, they can understand their discharge instructions better. They're less likely to leave AMA out of fear of getting sicker. And when they feel better, they are less likely to use an illicit substance overnight before they go to treatment the following day. We also know when patients receive a dose and avoid illicit use, they are more likely to engage in treatment within 24 hours. And when we look across our hospital data, we know that the patients who received a dose of buprenorphine in the emergency department show up at a rate of 65 to 70%. So there's a very high likelihood that they're going to enter treatment the following day. As you know, buprenorphine is a partial opiate that has a ceiling effect, and it's formulated with naloxone, so patients cannot get high. If the patient agrees to attend treatment the following day, the peer will verbally notify you that the patient should be considered for a dose of buprenorphine. Medication administration will only occur if a peer is available and when a same day or next day appointment can be arranged. The provider is the one who will ultimately determine whether the patient is approved for administration. There are a few things the provider should take into consideration, which includes determining whether the patient meets DSM-5 criteria for opioid use disorder, whether the patient has any contraindication to the use of buprenorphine. If the patient meets any of these exclusion criteria, they are not eligible to receive a dose. So if a patient reports that they are on long-acting opioids, if there's evidence of liver disease, an acute psychiatric illness, or an allergy to buprenorphine. Cautionary criteria that should be used but should not exempt a patient from being able to receive a dose include whether they are prescribed or illicitly using benzodiazepines and whether they report that they're pregnant. If the patient meets criteria to receive a dose, the provider will place an order for the clinical opiate withdrawal scale, which the nurse will administer to determine the patient's level of withdrawal. If the patient scores 8 or greater on the clinical opiate withdrawal scale, the nurse should notify the provider. The provider should then order 1 Suboxone 8 mg sublingual tablet and any ancillary medications to support a patient in withdrawal. Nurses should administer the medication and observe that it is taken in the way the patient has been educated by the nurse while in the emergency department. Here I have displayed for you screenshots of the MAT order set that you should order for the Suboxone 8 mg tablet. And displayed here is the DSM-5 criteria that should be used to determine if the patient meets criteria for an opioid use disorder. Here I have included a few tips on preventing precipitated withdrawal. First, we know that precipitated withdrawal is more likely if a person's level of physical dependence is high, if there has been a short time since their last use, or the initial dose of buprenorphine is too high. To prevent precipitated withdrawal, the first dose of buprenorphine should be administered when objective signs of withdrawal are present. While the provider and nurse are working on administering the patient's buprenorphine, the peer recovery coach is arranging for the patient to be referred to a fast-track provider. Fast-track providers is an existing network of community providers Mosaic has worked with that have committed to receiving patients from Summers Emergency Department who has been dosed. These providers are ready and willing to accept patients from the emergency department the same day or next day for continued maintenance. Each fast-track provider has a unique protocol the peers will follow to schedule patients an appointment. The peer recovery coach will not recommend a patient to the provider to be considered for a dose Unless the patient has confirmed they will attend treatment and there is a likely available appointment the following day. A few confirmed fast track providers for Summers include FMRS, Three Rivers Clinic, Anchor Medical, Bright Heart Health, and Lifeline Addiction Specialists. The Reverse the Cycle program will be going live at Summers on June 20th. The peers are in training with the Mosaic Group the week before go live. Tiffany Latham is a senior behavioral health consultant with the Mosaic Group, and she is a primary consultant working with Summers ARH to support this program. She will be providing in-person and remote support to the peer team and any other clinical staff throughout the process. Her phone number and email are listed here. She will be checking in with the peer team almost daily and working with the planning team to continue with the support of implementation. Thank you so much for your time, and please reach out to Tiffany with any questions you have. Have a great day.